This is very common practice in the fertility sphere that we are always in touch with our patients, and that's very important because they need to know the next steps. They need to be aware about the whole process.
IVF with own eggs. How is the process organized for patients coming from abroad when it comes to treatment with own eggs?
Very similar as for the oocyte donation. If patients are traveling from elsewhere, specifically from Ireland, if these are patients who are not for the first time in IVF, they are usually well aware about the whole process. So we need just to coordinate them for the days, for the visit, for the prescriptions, for example, sometimes for the medications and scan and hormones, which they are doing in Ireland. But as we are collaborating with many centers here and many physicians in Dublin and around Ireland, we may coordinate the stimulation of patients from their home countries and home facilities. We are getting information about the stimulation protocol, which we prescribe to the patient. We ask the patient to do a scan and hormones in their home country. Then they are sending us the reports. We are controlling their monitoring in the chat. They are receiving answers within few hours after they got their information about scans and they know about their next steps. So this is very common practice in the fertility sphere that we are always in touch with our patients, and that's very important because they need to know the next steps. They need to be aware about the whole process. Sometimes we cannot predict where and how the next step should happen. However, if we are in constant contact, this is how we go through the whole process with our patients. It's always together and always informative, like in details.
So how long should patients expect to stay in Slovakia if, for example, before the egg retrieval procedure?
Depending if they are having their local physician and their local facility who can monitor them, they should come as late as the day before the egg retrieval. If they don't have a proper place for their monitoring or they want to be under our supervision during the stimulation process, they are coming on day 2 while we begin the stimulation, and they are with us for next 10 to 15 days. However, majority of patients would choose to come later, and that's why we coordinate their stimulation with their local clinics.
In terms of treatment with own eggs, do you prefer doing fresh transfers or frozen, or is this also based on the individual case?
Majority of treatments which we would recommend to do genetic testing for the embryos. And there was a shift in the belief, and that's proven based on the evidence that frozen embryo transfer work better because of normalized hormonal conditions and not super physiologic levels of the hormones, which we usually have after the oocyte retrieval process. And when we are limited in time for the genetic testing, we cannot perform the genetic testing, then we don't know which really embryo we are transferring. And majority of our patients, they are more complex cases, more complicated cases. For them, genetic testing would be really reliable solution and sometimes the game changer because many patients, they may struggle of receiving euploid embryo, and without genetic testing, based only on the morphological characteristics and development, we cannot really know what's inside. And if you are transferring non-tested embryo, that can be partially a false positive expectation about how this may work. And then the risks associated with the potentially uneuploid embryos while transferring them, first would be that they would not implant. Second, that they will cause the miscarriage. And the miscarriage would call the recovery for the uterus, potential risks of the next surgeries, chronic endometritis, and different issues which can be long-term and which may really lead us to the more complications. And the third can be that this embryo will still keep developing, and that will be an embryo with the genetic disorders. So that's something what we would like to avoid for our patients.
So in those cases of genetic testing, you would do the frozen transfer, and this is how you decide sort of whether fresh or frozen would be recommended.
We do biopsies on the blastocyst stage, and for the genetic testing, it takes some time. In our cases, this is between 7 to 10 days to get the results of the biopsy back. Meaning that once we develop the embryo till blastocyst stage, this is already day 5 or 6 after the egg retrieval, and then we need another 10 days for the results to be back. So patient is not already in her implantation window anymore. So we would freeze the blastocyst while taking the biopsy, and patient will be prepared for the next transfer as the frozen embryo transfer in the next months or later.
And how do you assess for which patients the genetic testing would be advantageous to have?
That's based on their previous medical history and based on their implantation results. And also the fact if they had, let's say, miscarriages, because miscarriage can be also very often associated to the embryonic factor. So once we can solve the embryonic issue, other issues are the uterine and the extrauterine. So these are 3 main streams which we need to have all the answers for: embryonic, uterine, and the extrauterine. And if we are completely clear about all 3, then we are ready for the embryo transfer, and this embryo transfer would be most likely successful.
I often also talk to patients who are over 50 coming from Ireland, looking for places abroad to have treatment. Which places in Europe can they opt for?
We are not aware about such places. In Slovakia, there is no formal limitation of age, but there is an ethical consideration about treating such patients. In our practical experience, we do have Albania as one of the potential places where patients over 50 can be treated.
And what are the considerations when treating patients closer to 50 or over 50? Are there any risks that they should be aware of?
They are advanced maternal age patients, and if you're talking about potential of those patients of creating their own embryos, we need to understand that we are limited with their potential of producing the cells. So majority cells as oocytes. Majority of those patients would look for the oocyte donation. Implantation potential can be still fine, and absolutely we know many patients who used to be successful with carrying the pregnancies and healthy live births in their over 50s. It's more a question of the ethical considerations of being a healthy mom of the newborn and taking care about the development of the baby.
And could you tell me more about why patients from Ireland tend to choose your clinic when deciding where to go for treatment abroad?
So we are having several clinical locations, and those clinical locations are different in terms of the regulatory perspectives and the treatment which we may perform there. For instance, regular IVF treatment and oocyte donation we can perform in Slovakia. We do MRT procedures in Albania. We do surrogacy treatment in Ukraine or Georgia. So depending which treatment patients would be looking for, they can choose the destination which will be exactly for this kind of treatment available.
Do you have a case in mind of maybe a patient from Ireland that you have worked with recently that you could tell me a bit more about?
I can tell you about one case from Ireland. That's a patient we met very recently in our clinic for the frozen embryo transfer of her second embryo. And her first embryo transfer with us was 3 years ago, after which she successfully conceived and delivered a boy. So they came with their small boy, who was already 2, into our facility very recently. They had 2 euploid embryos with us after MRT treatment. And her background was that after 6 IVF cycles in which she started in her 39. She never had blastocysts before. So patient had an issue with the embryo development arrest, and she was a patient for the MRT, Mitochondrial Replacement Therapy. As a result, in her first round of the treatment, she received 4 oocytes. In her second round of her treatment, because we accumulated her eggs, she received another 4 oocytes, and we ran the MRT with 8 eggs, and we resulted with 2 euploid blastocysts. And these both euploid blastocysts worked because recently she was for the second transfer, and we just learned recently that she's clinically pregnant. So the small boy is going to have another brother very, very soon.